Hello, everyone, and thank you for joining us. I'm very delighted to introduce this conversation we're going to have with two terrific physicians, Dr. Paul Byrne and Dr. Christine Zainer. Dr. Byrne is, I think it's fair to say that he's the founding father, or maybe among the founding fathers of neonatology in the world. He was one of the first persons in the early 1960s to start a neonatal intensive care unit at a time when there was virtually no equipment to treat little babies and premature infants. And he helped design and adapt ventilators and little blood pressure cuffs and the instruments that you would need to take care of little children. And in doing so, developed the field and helped countless of people and around the world. And Christine Zainer was an anesthesiologist. She practiced anesthesiology in Wisconsin. And we're having the conversation with these two physicians on the topic of brain death and how the encounter with the diagnosis of brain death changed, how they reacted to it and how they changed their practices. So there are a couple of things that I want to bring to your attention. One is, unfortunately, halfway through the conversation, the audio quality, specifically from Dr. Byrne, starts to drop out, and it becomes a little bit more difficult to follow the conversation, although it is still possible to do it. And but I want to give you a warning so you can maybe pay a little more closer attention at that point. But it's still a terrific conversation. And then I want to bring to your attention that the next episode, it's a conversation between me and Dr. Coca on the topic of brain death, just the two of us, because as you will see, Dr. Coca is less than persuaded by the arguments that we made against brain death. And so we decided that we would try to hash it out on a separate episode. So that the episode that follows will be just Dr. Coca and I talking about brain death. Thank you very much for joining us, and here's the new episode. Dr. Paul Byrne and Chris Zainer, thank you very much for joining us on the Eckhart and Coca report.
Thank you.
This is I'm very happy to have you, both of you. You're both are very dear friends and examples to me on in how you've engaged with the question of brain death, which listeners of the show know that it's a very a dear question to me. And I would like to introduce them to both of you, and I would like the audience to hear your story. I want to start with you, Paul, Dr. Byrne. Because you're a real, pioneer is not the right term, but a prophet. I think a prophet is the right term in how you've engaged with the question of brain death against all odds, the lone voice in the wilderness for the longest time. I want to know about what you were doing up until the paper that you published in JAMA in 1975 or 76, I think. Correct me if I'm wrong. I think the date may be off by a couple of years. But you published an important editorial in JAMA, and maybe the last opposing view, the last viewpoint in any major medical journal opposing brain death. Am I correct? Was that the last? Has there been anything in a major medical journal opposing brain death since you've published that editorial?
Well, first of all, it was not an editorial.
Yeah, that's right. It was not. Correct.
It was a document that we submitted to the Journal of the American Medical Association, and it had multiple pages. I would just say 80 typewritten pages. Had multiple references. I would again say about 100 references, and it took them a bit, but they said yes, they would publish it, but only 20 pages and no more than 20 references. So that's the first thing that was our first major publication. I had published another article in the Missouri Medical Journal 2 years earlier than that on a similar subject that came at the issue in question from the angle and point of view of a neonatologist. Now, I say a neonatologist. I started as a special care nursery at Cardinal Glennon Children's Hospital in 1963, when really there were few, if any, treatments for sick newborn babies. And it wasn't until about 1970 that we made some advance in helping babies to breathe. So I was there at a St. Louis University, a major medical school university, at a children's hospital doing neonatology, and I would say a semi-leader in the field. And I had a patient by the name of Joseph. Joseph was born prematurely, and he was on a ventilator. And after several weeks on the ventilator, he wouldn't move. He would just lay there. We couldn't get him to do anything, couldn't get him to take a breath. And one of the fellows that I was training suggested that we get an EEG. So we did the EEG, and it was flat. The official interpretation was consistent with cerebral death. I would just tell you that the EEG was reviewed by multiple neurologists to verify that that interpretation was correct. It was then suggested that that we stop treating Joseph, and I said,
What year was this? What year was this?
1975.
Okay, so that was after the Harvard's committee had published its criteria for quote unquote brain death. Okay,
correct.
And by then the practice of declaring people brain dead was pretty widespread.
Well, it was. Let's put it this way: it was after the Harvard criteria, the Minnesota criteria was published in 1971. To put that in perspective, and then there were multiple sets of criteria. Actually, between 68 and 78, there were 30 disparate sets of criteria that were published. So it was suggested to stop treating Joseph. I said, well, I treat little babies, and some live, some die, and keep in mind that when I started to do neonatology, every baby less than 1,500 grams, which is 3 pounds and 4 ounces, that had trouble breathing, died. It was 100% mortality. Mm-hmm. That's why I started. And many babies much larger than that died also. There were, and so certainly in the beginning, it was common that a baby would die, and we treated them in the best way we know how. In the beginning, we knew little or nothing compared to what's known now. But in any event, I said, well, I will continue to treat Joseph, which I did. And after a bit, Joseph was able to be weaned from the ventilator, and he breathed on his own, and we continued to treat him. To make his story as brief as possible, when he went to school, he got excellent grades. He married later, has 3 children. So that was the story of Joseph. And so my early study of the question was, what is this all about? And so I asked the neurologist if for some articles about brain death, and he said, "Oh, Paul, don't be concerned about it. It doesn't apply to anybody under the age of 12." And so at that time, 12 was the age that they didn't use brain death under 12. And they quickly, I say quickly, at about the same time, lowered it down to 5. So it didn't apply to any child less than 5 years of age. And so I studied, and it was 2 years before we published the article. And the early study involved learning the language to see what they were calling brain death. And of course, you mentioned the Harvard criteria, which was published in 1968. The title of that article was A Definition of Irreversible Coma. And that became known as the Harvard criteria. And of course, right up front there with coma, coma can happen only in somebody who's alive. A cadaver doesn't have, sorry about that, a cadaver doesn't have coma. And so there's a difference. Now, the other thing I would tell you about my early study is a Jesuit priest, Father Paul Quay, was at St. Louis University, and we got to know each other because we both were invited to present in the same building, but on different floors by different people on somewhat similar subjects, although I can't tell you for sure what his presentation was. But we met at that time, and after a bit, we started to study together. So he was a theologian and also a physicist. He graduated from MIT and published articles on microthermal units, that kind of thing. Also a theologian. And then Dr. Sean O'Reilly, who was a neurologist from Boston, joined with us, and then an attorney, Peter Salsage, who was the dean of the medical school, dean of the law school at St. Louis University. And so that's how we started. So we came from multiple disciplines and communicated often, asking questions. How do we go forward with this? And I have to tell you that early on, as I identified that there was a problem here, and we identified that there were problems, we had an agreement that amongst all of us, that if it was shown that we were not correct, then it was our obligation and responsibility to quickly write something to straighten the matter out. Well, here we are more than 40 years later, and that has not occurred. And fact of the matter is, as it goes on, I have to say that my early study from the vantage point of a pediatrician, a neonatologist, and keep in mind this little bit. In 1967, I was asked if I would go to the legislature and give some testimony as to when human life began. And so that caused my concentration to be on chromosomes and DNA and that kind of thing. And I did testify at the legislature, and we were successful at stopping abortion in the state of Missouri and until Roe v. Wade in 1973. These dates are important to put it in perspective. So with that study of DNA, the DNA can be used to identify the uniqueness of each one of us from in terms of each one of our cells is specific for us, identified by the DNA. The DNA isn't the cell, but it's in there in the identify the person. That up until then we were used to identifying people by fingerprints or the like, and with DNA we can identify it in every cell of the body. And so it seemed to me that as a human person could be identified by the DNA in every cell, and then when it came to this question of focusing on the brain, what about the rest of the body? And what about calling, as they were calling somebody dead, when there was an absence of functioning of the brain, and yet the rest of the body was still alive. It just seemed to me that there was a problem here. And that's what my first publication was about, that had to do with the uniqueness of the person and how whatever was going on in terms of calling somebody dead on the basis of absence of functioning of the brain, it didn't make sense. And so,
right. When you were speaking with colleagues at the time, was there anyone else who raised the same questions, or who confronted the problem the way you did? Or did you feel that you were sort of alone trying to figure it out on your own, because everybody else was pretty much accepting brain death as a matter of fact?
I tell you that, at least from my perspective, very clearly how it was. It was from my own, and then a theologian, and then a neurologist, and a lawyer. And we published when I would say there was, I can't say, I should say, I'm not aware of any other articles that were published in opposition to brain death at that time. But then as time went on, and not a long time, I ran across Joseph Seifert, who is a philosopher at that time from Liechtenstein, and he was basically saying some of the same things. And then I came across Watanabe from Japan, and he was saying somewhat similar things. And then Wainwright Evans, a cardiologist from England, and actually at that time, then I started to communicate. It was several years later, but I started to communicate with all of them. The interesting things, Dr. Akkad, the interesting thing about that is that, yes, it did come into my life because of a patient by the name of Joseph, a tiny little baby. Incidentally, his mother insisted that he was 18 weeks gestation. I could never get her to agree to anything more than 20 weeks. So a very immature, premature baby. But because of that, because of Joseph, I started. And then look what happened at the same time at multiple places around the world, England, Liechtenstein, Japan, same things were coming about. And actually, every now and then, I get an idea that I think is from me, and then I find out, no, there's lots of other people have the ideas also, and then it's a matter of pulling together, and eventually we have somewhat work together. And I mentioned some of the people, and we did put on a conference at the Pontifical Academy of Sciences in the Vatican City in 2005, and several of these men that I have mentioned were there, and actually our presentations are published in a book entitled Venus Vitae, and Is Brain Death True Death is the title of it, and we published in that, and so
I want to get into the stories
there.
Dr. Byrne. I want to get into the stories because they're actually fascinating. Sort of the background, the response from the religious authorities to what you were trying to say, particularly at the Vatican and so forth. But before we get there, did your thinking evolve where at first did you just think that brain death was an inappropriate diagnosis, so to speak, or it was inappropriate to declare infants dead on the basis of the lack of brain function, but perhaps it might be okay for adults who had a more mature brain, and if there was no brain function at that point, maybe it was okay. And then you changed and started thinking that no, this concept is just false altogether. That there's no.
Well, to put that in perspective, it didn't make any sense to me because from the frog lab, if something was done to the brain, it had an effect, and it didn't make any difference if it was a small frog or a large frog, or a young frog or an old frog. The effect was the same. So it didn't make any sense to me about how this can be going on in people older than 5. And actually it was 12 when I started, but older than 5 when I started to work more intensely on this. It didn't make any sense to me how this can happen. And then the other thing I would tell you, just so you know, I didn't just immediately scrap everything. I said, maybe there's a way to make something correct about this thing called brain death. So I studied 275 babies, and I looked at the creatine phosphokinase, the BB fraction. You cardiologists are used to looking at that from the point of view of damage or injury to the heart muscle. Well, there's also an enzyme that's released when the brain cells are damaged. So I looked at 275 babies, and I compared, I think that most all of them lived, but what was the difference? The difference was those who had the markedly elevated creatine phosphokinase were sicker. They stayed in the hospital longer, but they didn't die. And so at least that test was not adequate to support something like brain death. And so it wasn't that I just embarked on this, if you want to call it crusade, because I didn't do that. I was still an academic physician studying, doing my neonatology work, but then concentrating on brain death and that kind of thing. We did many other things in our nursery also besides that. So, but that's how I started, and then patients have continued to come into my life. TK is one that a lot of people hear about. TK was one of my patients. I was not his primary treating physician. You have to keep in mind that I was the director of neonatology at that hospital. That hospital was in Omaha, and and TK was 4 years old, almost 5, and had developed meningitis. And then as that progressed, he was then said to be brain dead. So because of my interest in the subject, I paid attention to TK, and when his treating physician was out of town on the weekend, I covered for him. The nurse called me one evening, Friday evening perhaps, and said, TK's blood pressure is going down. And of course, by that time, he had already been declared brain dead like 2 weeks before. So I think to myself, what's this all about? And I said to the nurse, well, I would go over to the hospital, which I did. So there was TK in a child's bed with side rails, and his mother was sitting next to him, and his mother was Renee, and I said, Renee, and TK, I called him by his first name. I said, TK's blood pressure is going down, and I said, would you like for me to do anything about it? And she looked up at me and said, well, what can you do? And I said, well, we have medication that we can give, and sometimes the blood pressure will come up. I said, I can't assure you that it will. Keep in mind, brain death on his chart, brain death concentration. I said, and so she looked up at me and she said, well, get on with it. Her exact words. I gave TK his medicine for blood pressure, and he wasn't on it very long, maybe about 48 hours, and then was able to be weaned from a blood pressure medication. And he lived another 20 years without ever needing anything for his blood pressure. TK got reported, but my name is not attached to the reports about TK, but he was my patient. So it's kind of interesting how these patients have come into my life. Some I know about how they come and that kind of thing. Others, people call me and then I get involved that way.
Sure. So for the audience, I just briefly mention here that so TK was published. It became a very important case because it was well documented that he survived, that he had really met the criteria for brain death. And when the concept of brain death was introduced and then had to be legalized, so to speak, there had to be an argument to justify why we would call people with absent brain function, why would we call them dead? And the big debate was, are there two different kinds of death? Is the brain death one kind of death, and then there's another kind of death and whatnot? And the political authorities, the legal authorities, wanted to make sure, and to this day it's still part of the law, that really there's only one death, that when somebody is declared brain death, it's the exact same physiological event. Biologically, the organism is dead. And the justification for that at the time was that the reason one can call a body that doesn't have a functioning brain, call it dead, was because allegedly the brain is the integrator of the body, and allegedly the disintegration of, right, it's what you have when you declare when a person is declared brain dead. What you have is a collection of organs that are maintained alive by the intensive care, but the decomposition is imminent. That it's just a matter of weeks before the body is going to putrefy, and that we may as well just declare them brain dead, declare them dead immediately, and take them off the ventilator and either dispose of the organs or bury the body one way or the other, or donate the organs. because otherwise it'd be a sort of an unnecessary prolongation of this decomposing process. And it became obviously a self-fulfilling prophecy, because each time somebody would be declared brain dead, then either the organs would be donated and they'd be, you know, killed in the process, or the ventilator would be disconnected and then they would die a traditional death, so to speak. But there were very few cases of survivors of brain death, and TK is one of them, maybe the most notorious. And Alan Schumann, I think, may have published that case. He was a guest on the show. We'll have a link on the show. But eventually, a number of exceptions to the prediction that brain death was actually an indication of the decomposition of the body, of the putrefaction of the body, an early sign that the body was no longer a body. Many exceptions were published, so that by the time the late 1990s or 2005 rolls in, when you talk about this conference that you had at the Vatican, there was a lot more. It was the concept was a lot more problematic, even though the practice has continued and continues to this day of declaring people brain dead as if they were really dead. And there's a lot of ambivalence, and people have learned to live with the ambiguity and the ambivalence of the concept. But you're right. I mean, TK was a remarkable case, because he survived many years, and there was no question that he was misdiagnosed, because at autopsy, I think when he finally died, there was no brain matter to speak of when the autopsy was made 20 years later, which essentially belies I mean, it shows that the argument that the brain is the integrator of the body cannot possibly hold. And I mean, it gave empiric refutation to that notion that that the brain has to be the integrator of the, you know, that brain dead is actual true death, and that's not the case.
Yeah.
Go ahead.
Yes, and you use the term integrator of the body. I don't believe, or at least I don't recall, that was the term that was used back when all of this started. And if you think about the term integrator, comes about and is rooted in another word called integrity, and put together in one. And if the basic unit of biology is the cell, and the cell isn't simply a nucleus and cell membrane and cytoplasm, but it has an integrity, but it also is integrated. And then cells are integrated in terms of tissues. We keep using that term, integrated, and then cells, tissues, or integrated in organs, and then cells, tissues, and organs are integrated for function. There are 11, in accord with systems, there are 11 systems in the human body that are identified in terms of function. Each one of them has integration. And what life has to do with this is an interdependence of these systems in organs that maintains the unity of the body. And the unity of the body is there when there is the life, and the human being is physical and spiritual. And we can study the unity of the body, and when the unity of the body is there, we can know that the spiritual is there also. Now, one of the things that has occurred in all of this in more recent times is the focus on integration. That is not what the focus is on in terms of death. The focus in terms of death is on disintegration, is on destruction. And we to put the thing about the laws and that kind of thing, and then this thing, the the focus early on in the laws was to make brain death be death and be the only aspect of death. And there was the American Bar Association definition of death. And about 2 years later was the Uniform Brain Death Act, again on the focus on just the brain. And then eventually we get to the Uniform Determination of Death Act and the President's Commission in 1981. And as you said, they put in there more than one way, but the declaring dead, but that was only after they couldn't make brain death be accepted. And so then they had two different ways in terms of being dead. They really wanted brain death, but then there was this thing that had to do with someone stopping breathing and their heart stopped, and then for sufficient amount of time, there was disintegration or destruction. Putting all of that together, we published an article in the Gonzaga Law Review. It's 85 pages and has 245 footnotes and with multiple references, and to put in this thing in terms of what was happening, so that brain death was wrong so far as the law uses irreversible cessation of all functions of the entire brain. You can't observe irreversibility. A doctor can't observe that. He can learn something about it, but there can be observed an absence of function, and there can be observed by destruction, and that's within what doctors can do. And early on, this thing happened in medicine, and where were the theologians to object? And then the laws got involved, and the Uniform Determination of Death Act, which was either 1 or 2. And as I went to multiple places, I can remember going to Pennsylvania to point out how death is not either 1 or 2. And then I pointed out to them how if you can make death be either 1 or 2, why can't you make it or 3 or 4? So what their response to that was, Pennsylvania has, in terms of their statute, they put in the word only, so it can be only 1 or 2. Now, that didn't solve the problem, and all it did was give a response to me, who was trying to point out how there's not more than one way to be dead. There's only one way, and the one way that has to do with death has to do with disintegration, destruction. So the question is how much destruction has to be there before you declare someone dead? And what we published in 1984 in the Gonzaga Law Review is we published the statute that was model statute in the negative. We didn't say a person is dead when, and actually the Uniform Determination Act, Death Act says an individual is dead when. Individual, that's not what persons are. You can have an individual chair. You can have an individual desk. Anything can be an individual. So individual gives problems. So what do you do? It needs to be written in the negative. No one shall be declared dead unless there is destruction. So the question is, how much destruction does there have to be? And the interdependence of multiple systems of the organ, of the body, to maintain the unity of the body in the vital systems are the circulatory system, the respiratory system, and the brain. So no one should be declared dead unless there is destruction of those three systems. But death involves destruction, disintegration, and that has to be there. And all the laws are written in terms of an absence of function. The American Bar Association definition of death used the single function, a total brain function. We wrote in opposition to that in our JAMA articles, focuses on that. And we pointed out to them that there isn't just one function, there's a lot of functions. Then we also pointed out to them that if you use total brain function, then any function would not be total brain function. So that's how those laws came about, to use cessation of all functions, the plural, of the entire brain. And then look what they did. Just think about it. Irreversible cessation of all functions of the entire brain. And then they said, including the brainstem. And I said, how can you have the entire brain and not have the brainstem? All of this was a matter of satisfying some people who were objecting, and I know some of those people, some people who were objecting and saying, well, much of the focus is on the brainstem. And they said, well, okay, let's throw in brainstem too. And so, and of course, how this all came about is brain death is not true death. It's not death at all. It's when someone is called brain death, they have a beating heart, circulation, and respiration, and they put out urine, and they have bowel movements, and they digest their food. And to call that dead, you wouldn't call your dog dead under those circumstances. And so it was false to start with. It kept on being propagated. Not very many people drew attention to what was happening. We did what we could, and we still do what we can. And here I am. You're interviewing me.
I want to. You mentioned where were the theologians, and I want to get back to that question in a moment. But I want to give Chris a chance, Dr. Zainer, a chance to tell us her story and how you encountered the problem of brain death. You're an anesthesiologist. You were practicing. I don't know if you're still practicing, but tell us a little bit what your story is and how you confronted this problem of brain death.
I was a resident in 1983 to 1985, and at a major academic level 1 trauma center, transplant center. And as a young resident, I was told to go do this case, and it was organ harvest. And so it was in the middle of the day. It was just kind of added on. So I ended up getting thrown into this case, and I hadn't been assigned to it before that. I hadn't had any time to read about it. So I went and got the patient and brought him to the operating room. My staff anesthesiologist came in and said, just kind of quietly, well, give him some muscle relaxant, and if the blood pressure goes up, you can give a little anesthetic, but not too much. Make sure you watch the fluids, and the surgeon will let you know when you can turn off the ventilator. And so I was witnessing this case where they were harvesting the organs, and it just never sat well with me. This patient seemed to be like every other patient that I took care of that was unconscious and on a ventilator. And probably more stable than some of them. And I just never felt right about this. And so that was in the 80s, and I ended up having, I never got called to do another case like that. But I started asking around and trying to get more information about brain death, and got smatterings of information here and there, but nobody really wanted to say anything or commit one way or the other. And I hadn't known about Dr. Byrne at the time. And I also was challenged by a friend, a former teacher, very active in the pro-life movement, who at the time he and his wife were gracious enough to take care of my two children. I ended up having gotten divorced in 1991, and my children were being watched by these people. And I remember leaving one day, and this former teacher said, well, so how do you handle the sterilizations that come up? And I said, well, I do them, after all. It's not an abortion. So yeah, I go ahead, I participate in these cases, but that triggered my conscience. And that started a process of really looking at what the church taught on these beginning of life issues. And I ended up going to a conference in Omaha in 1993, the 25th anniversary conference of Humanae Vitae. And to make a long story short, after more years after that conference of prayer and reading Humanae Vitae, praying, reading what the church has taught, asking more questions, challenging people, I finally decided that I had to go into my chairman, even though, and I had to tell them I wasn't going to participate in sterilizations anymore. And I thought I was going to lose my job. And here I was divorced. I had two kids. I had a kind of a nice arrangement in terms of taking my call on a weekend when my kids would be with their dad. And but I thought, no, if I'm going to live, I became committed that this is the church's teachings, this is true. And so I couldn't continue to do those cases come what may. So I'm in the office with my chairman, who is a father. He's a Catholic guy, father of 5 children. And as I'm sitting there, literally, I have this sense that there's this voice in my head. I didn't hear anything audible, but it said, "Don't forget to tell him about brain death too. You're not going to do these cases either," because it never sat well with me. And I knew there was another physician in the community that desisted from these cases, and his thought, he had said, well, look, if they're dead, they don't need an anesthesiologist. So he decided he wasn't going to participate in these cases either. And so I said, oh, and by the way, and I like I said, and by the way, I don't want to participate in these organ harvests either. And he asked me, well, so when do you think somebody's died? And I said, well, when the soul leaves the body. And he said, well, when does that happen? And I said, well, I'm not really sure, but I'm not sure that when somebody's brain dead, that the soul has already left. But I know for sure that once we take everything out, they're really dead. And he just kind of rolled his eyes and shrugged his shoulders and said, well, okay, you'll have to take your call somewhere else. So, because I was taking call at the level 1 trauma center. So I'd get involved with the postpartum tubules, and I could have gotten involved with the organ harvest. And so I decided, well, I thought I could take my call at the Catholic hospital, which was known for its OB care, because our department, academic department, staffed the OB anesthesia part of that hospital. So after going through the credentialing process at this hospital, and they were always looking for people to do OB anesthesia because it wasn't a very popular thing for people to have to participate in. It was quite stressful. And so I got through the whole process. I had to go through a perfunctory meeting with the new head of the Catholic hospital. And I said, and by the way, I'm not going to participate in, I'm not going to be able, I'm a Catholic. I've come to believe what the church teaches, and I can't participate in these sterilizations. I've heard you do them here. And he looked uncomfortable and went through the meeting. It was pleasant. And I got a call a couple of days later from the head of OB anesthesia. And she said, well, Chris, you'll have to take your call somewhere else because we do these cases here, and we don't want to find somebody to take your place when you're on call. So I ended up at the VA and wrote out in my credentialing things, well, I'm not going to participate in these cases. And it turns out at that time, the VA, the patient population didn't lend itself to organ retrievals. And it didn't lend itself to sterilizations in the operating room. So I ended up taking my call at the VA. And so that was what happened. So it kind of got, those two life issues were sort of joined together, and that's how I got to that. All with the experience of having been taking care of a patient that was called brain dead. And a few years later, I got challenged by one of my colleagues, who she asked me if Terry Schiavo had been murdered. Terry Schiavo was the person in the persistent vegetative state, and the husband wanted to have the feeding tube withdrawn, or the feedings withheld, and he ended up prevailing in that. And my friend, whose mother was against this, thought it was a horrible thing. And so my friend knew where I stood on various issues, but she asked me anyway. She's kind of baiting me in the doctor's lounge. And so I said, yeah, I think she was murdered. And we got on the topic of brain death, and another staff came in and was overhearing the conversation, said, well, Terry Schiavo, she's brain dead, and I don't want somebody telling me, Bible thumping person telling me that I have to have this or that. And I don't want to be a potted plant. And so anyway, she stormed out, was all upset. And, but my friend with whom I could talk, we talked about how brain death isn't true death. And about a week later, we were in a staff meeting. And after the staff meeting, we were chatting with one of the other colleagues who worked in the part of the hospital where they do the organ retrievals. And the person said, well, I've got to get going because I got to go start this case, meaning the organ harvest, because they got to be able to declare this person dead. And my friend, we had this discussion. She looked at me and she looked at him, she looked at the staff, and she said, well, the patient's already dead, meaning brain dead. And he said, well, you know what I mean. So they can be really dead, bury them dead. And I smiled and I looked at her, and she knew exactly what the point that I had been trying to make, and what this person kind of admitted, that even though willingly and participating in these procedures. And that started a lot of more study on my part so that I would have a better way of looking at this. And Paul and I ended up meeting for the first time. It was 2004 at the Catholic Medical Association meeting in Florida. And at that time there was, I introduced myself, we chatted a little bit, and then there was a hurricane. And neither of us could leave the hotel. So we were stuck in this hotel, and I had a chance to really pick his brain and ask more questions and learn more about this. And then we subsequently have kept in contact and been friends, and I help is where I can with his writing projects and things of that sort.
Right.
And
you this is great because you really you took a big risk professionally, for your livelihood and to follow your conscience and to do what you thought was right. I think, Chris, you had an interest in drawing attention to the procedure called the Apnea Test, which is one of the things that fulfills the criteria for declaring somebody brain dead. And so tell us a little bit about this. What's wrong with the Apnea Test and doing this innocuous, seemingly innocuous intervention?
Well, I got to, as an anesthesiologist, we focus on airways, breathing, circulation, all those basics. But what kind of hit home on this and who articulated this, the issue of the problems with the apnea test, was Dr. Thomas Zabiega, who's a neurologist, who also I had known from the Catholic Medical Association. And I had written something online around the time that Jahai McMath that case was going on in California. Paul knows about Jahai very well. And I was challenging the whole issue of brain death and online. And I asked Tom to look at what I had written, and he wrote extra comments, and he said his recommendation is for people to avoid what's going on in California. Don't let anybody do the apnea test on your loved one, because once they do that, they can make the declaration of brain death, and then it takes the control effectively out of your hands as a power of attorney, because if you're legally dead, you don't have any say in this. So the light bulbs went on that. And so Paul and I started working more and trying to write more on the whole apnea test thing. that, and Dr. Zabiega pointed out very well too, that look, when they do this, this is going to make this could make your brain worse, because even though they may give oxygen, claiming it's safe, the carbon dioxide still goes up. And so that can, if there's residual blood flow going to the brain, that can increase blood flow to the brain and increase brain swelling, decrease actual cerebral perfusion, and cause what it's purporting to test for. And Ari Jaffe has written so eloquently on this in published articles, as well as an excellent book chapter on this. And so that's when we got involved and started trying to focus. Paul was helping, saying we should focus on the apnea test and writing about that. And that's when we presented that at that conference with the University Faculty for Life in Minneapolis.
Right, correct. A very important point, because you're right. I mean, so far, this is the only time where one can intervene and stop the sort of the train, right? The train in its track before stop it from going further. Now, it obviously, I think you must be you're triggering a nerve, because the pro-brain death side is trying to now pass a law to prohibit families from consenting to the apnea test, and having doctors do this intervention that has never been proven to be safe, right? I mean, there's no data to show that stopping a ventilator for 10 minutes or more is a safe procedure, and there's many good reasons to believe that it actually can be harmful and cause the brain injury to be even worse.
The other person who's talked about this early on was Dr. Cicero Coimbra, who's a neurologist and neuro researcher from Brazil. And he had videos that I had watched, and had talked about this in the dangers of the apnea test procedure. And Paul has pointed out very rightly with his excellent command and use of precision language that it's really a procedure. And it's even mentioned that in different peer-reviewed publication talks about it being a procedure. And so we try to refer to this as the procedure of the apnea test when we talk about it, because it involves taking away the life-supporting ventilator. It involves insufflating oxygen, which can depress the lower brainstem centers that respond only to hypoxemia. And of course, you're not going to try to make somebody hypoxemic. So why would you try to make somebody hypercarbic in the face of a brain injury? And Dr. Zabiega even had written that when he presented this information and presented in that way, would you ever put anybody in a coma and make their PCO2s purposely go up? You may not be actively trying to hyperventilate them like maybe had been done in the past, but you certainly aren't going to try to make them hypercarbic on purpose. And so that part of physiology seems to have escaped a lot of physicians in all of it.
But you're absolutely right. It is a procedure. It's an intervention. It's an intervention which, normally life is, I write, so I'm not going to tell about how I got interested in brain death. I mean, that would take too long here. But when I did, I started reading about how scientists think about life. And there was, and some scientists, they're actually, there are, it's not a fringe, but it's sort of a marginal science. There are groups of people who are interested in trying to find life in outer space, for example, or maybe some people who are interested in evolution and trying to decide how does life starts from inanimate matter into animate matter. So all these people need to have a pretty good definition of what life is in order to proceed with their science, right? I mean, if you go in outer space, how do you know that you've discovered a life form, right? It may not look anything like anything. So they need to come up with definitions. It's impossible to come up with the definition using sort of reductionist scientific terms. But they made the observation that the recognition that something is alive is extremely well conserved. I mean, even animals, all animals can sense that something else is living immediately and can differentiate living from something that's living from something that is dead very quickly. Even babies, infants can do that. I mean, if you test infants, they can tell something that is a living organism from a non-living organism very quickly. It's very well conserved. So really, to decide if somebody is dead or a body is dead, it's really a matter of observation. Whereas with brain death, it's a procedure. You actually proceed to you do a maneuver. It's a maneuver that you employ to try to elicit a lack of response, and it's because the concept is so weak and flawed to begin with. But that brings me to a question that I may want to ask Paul again before we get briefly at the end towards the response of the theological authorities. Paul, is there an opportunity? I mean, did you see that that all of a sudden there was a lack of interest once the brain death is widely accepted in trying to, especially maybe for infants, but maybe for adults as well, trying to develop therapies to help people with severe brain injuries? Because now, if somebody has a severe brain injury, you quickly go down the route of brain death. You apply the apnea test and whatnot, and then you view the body as a potential donor for organs. And there's an opportunity cost of not developing, for 30, 40 years, doing very little research in terms of trying to salvaging people with severe brain injuries.
Well, what I would say is the first thing is that most people know little or nothing about what they call brain death, and that includes physicians also. And they're going along in the world thinking, I guess it's okay. My own self, when I started way back when, I trusted the ophthalmologist, and I trusted the urologist and consultants, the cardiologist, and I trusted neurologists. So why wouldn't we trust the neurologist? And so as physicians, we trust each other, only to find out, and it's been done without education of physicians in general, and it's been done without education of the people in general. And when people are educated, when people learn about it, and over the years, I've had multiple physicians come to me, challenge, and I get them to thinking about it. And multiple physicians have changed from being pro-brain death to against brain death. Incidentally, Dr. Schumann, you mentioned his name, he was one of the leaders in the pro-death movement in the United States. We had multiple discussions, and I can remember them vividly, and I would come up with things. The thing that I came up with that was very significant, I thought, was healing, that the patient who's declared brain dead heals. Mm-hmm. So how can that be death? And then along the way, I gave up. I told my wife, I said, I can't do anything with changing Alan and going forward. And so I kind of gave up, didn't have contact for a while. And then he called me one day and said, Paul, I've changed my position. And so physicians who get educated and think, realize that there clearly is a difference between being live and being dead. And once you go that route of destruction sufficient to say that the interdependence of the organs and systems is not there, then you can declare death. But once death is there, the disintegration is ongoing. It's ongoing. You can slow it down by embalming or cooling or something like that. But it's clearly different. Death is different. It's an absence of life. And yes, you can observe the life when it's there, and it's an absence of life. You used the term elicit a non-response in terms of brain death. I thought that was a pretty good destruction. how can you elicit a non-response? You can't do it. It's under those circumstances, maybe a non-response, but you can't. It's not a sound thought process to say that something is there by an absence of something, unless it's the absence of life. And you, in some ways, you get into these a philosophical destruction in terms of when the soul leaves the body and that kind of thing. But you can do it in the negative and say no one can be declared, no one should be declared dead until there's destruction of those systems. Keep in mind, that's not really saying the soul left the body.
Right.
That isn't what we said. Although we said that the manifestation was such that the body could then be treated like a dead body because nothing more was going to happen. You can't do that in terms of absence of functioning of the brain. And you mentioned a little while ago the early studies. Some of the people said, well, they would die within a week. That wasn't so. A collaborative study showed that they didn't die quickly, and some of them didn't die at all. 44 of the patients of the 500 patients in the collaborative study did not die. And then they investigated the brain, and about half of them didn't have destruction of the entire brain. And so this whole thing isn't simply a mistake. It's false. And when it's known to be false, it's a lie. And brain death is a lie. It's been a lie from the beginning. It continues. And then, like all lies, once you tell one lie, you have to tell two more to try to substantiate it. And it's been going on beginning overtly in 1968, but it was really starting to come on before that, maybe a long time before that, but it becomes clear in 1968. That also had a major effect on the practice of medicine. Practice of medicine was different before that because every patient was a privilege to take care of the patient. And then if we could make the diagnosis, and it was so exciting to have a treatment. And then what happened was the brain death came along, which said you could call somebody dead while they had a beating heart and circulation and respiration. And that was contrary to good sense. It was false. And they kept on that, and they propagated it to where we have it now. And yes, they are trying to change the law so you don't have to get consent to declare brain death. Incidentally, that comes right out of the Aiden Halou case that we participated in, and as a result of that, and got a hearing at the Supreme Court in Nevada, and got a 7-0, a unanimous decision that the Supreme Court was not satisfied with what had happened, and they referred it back to the lower court to reconsider. And then Aiden Halou did die. But then what happened? The legislature got involved and put it into the statute. You don't have to get permission from somebody to do the apnea test, and other things you don't have to do. It's in the statute, and they have it already in Nevada, and they want to make it so it can be every place. But programs like this and yourself, Dr. Rapat, it's so commendable that you will take the issues that came in your life and say there's something wrong, and you keep on working on it. I encourage you to keep it up. And Chris Zainer also. We're so blessed to be able to think and not get caught into whatever somebody else is telling us and going forward in these serious matters of life and death.
Thank you, Paul, very much. I mean, we're a little bit past the hour. I don't want to keep you much longer, and the sound connection has deteriorated a little bit. I wanted to talk about briefly that, I mean, it's a lot of people now, at least in the in the secular medical world, will say, well, it's we don't know. They'll adopt an agnostic stance and say, well, we don't know really when people are dead. And we may as well just make it arbitrary for whatever is best for the greater good, and organ donation is good, and therefore we should be allowed to declare when people are that people are dead on that basis, whatsoever. And everything else is sort of a religious preference, if you will, or has to do with religious belief, and we can't allow that in the public arena. And what's remarkable is that you've had a very poor, unfortunately, so far. I'm hoping it is changing, but the church has widely embraced, by and large, the concept of brain death so far, and has not been as critical as we would hope it would be. I think this is changing quite rapidly, but nevertheless, there's a lot of deference on these questions to the medical establishment. And what has been your experience, Paul? I mean, am I painting a correct picture here?
Well, as far as the church is concerned, many of the documents of the church have been very, very clear that Pope Pius XII in 1957 gave some acknowledgement to the importance of doctors in these matters. But he said we are to presume that human life continues as long as vital function is present, even when supported by artificial means. And the teaching of the church has been such that it really hasn't been erroneous. It has been propagated in that way. They refer to, many people refer to a presentation by Pope John Paul II, and they refer to basically a paragraph that Dr. Joanne Ian, by the way, has published clearly in opposition to that, and helps us understand where Pope John Paul II was at that time. And I mention her because she's done an extensive work, and it's a book that needs to be in everybody's library if they're going to study this subject, Dr. Ian, and it has to do with this new thing of the definition of determination of death and that kind of thing, and she puts forth also, and I say also because in my study of this subject, it always been not only to get people to realize that there's something major wrong with what they're calling brain death, but to find better ways to treat patients and that kind of thing. And Dr. Joanne Ian also emphasizes that in her writings, and I don't have the title of her book.
I'll put a link on the show notes.
But
she was a guest
yes.
on the show before a couple of times, and we'll put a link to the show notes. You're absolutely right. Her book is magnificent. It's
Yes.
really extremely important. But you're right. I mean, at the end of the day, if we're able to believe or to convince ourselves that there's no distinction between life or death, or something that is alive is actually dead, or vice versa, and whatnot, then how are we surprised that we can believe all kinds of nonsense, right? I mean, if we if we agree to believe this nonsense, then everything else is up for grabs, and we shouldn't be surprised that we live in a world where
And
up is
that's
down and
where
down is up.
many of the difficulties occur in medicine because of going in the wrong. I say medicine made a sharp left turn in 1968 because the approach to medicine changed as a result of this. And there are many good things and exciting things about medicine. I'm not against the practice of medicine. I'm not against that, but I take a clear stand that brain death is not death. And incidentally, look what we do. I said brain death is not death, and that's the proper use of the word death. See, when brain is a noun and death is a noun, when you put two nouns together, you have to hyphenate them. The only thing that modifies the noun is an adjective. And brain is a noun. And so it's even the use of it linguistically is false. And the whole thing is false, and it continues on and on. And it has to be straightened out. And I think in a few minutes ago you alluded to the fact that we perhaps didn't get as much publication about this as perhaps we could. But you see, what happens is that if people find out that brain death is not true death, then there's something wrong with taking of organs, and there's something wrong with cutting out the beating heart, and that kind of thing. And once people realize there's something wrong with that, then how many other things are not going in the direction? And we're in the middle of the COVID pandemic, and many of the errors of thought that have gone into this pandemic are similar to the errors of thought that have gone into the acceptance of brain death. And I politely say errors of thought. They're clearly misleading the people and many of the things that are going on with COVID, and they're misleading the people in brain death. Brain death is a lie, and it's a lie that much of what I've done is to untell the lie. The truth is very easy, because we can know that life has begun at conception, and we can know that life is a continuum until death. And the death, of course, we're talking about is death, not the modified thing, whatever it is that has to do with an absence of functioning of the brain. But death is when the soul separates from the body, and it is manifest by destruction. And it's not arbitrary to say no one shall be declared dead unless there's destruction of the circulatory and respiratory systems and the entire brain. That's not arbitrary. It's making an observation by which you can be assured that life is not going to come back by any ordinary ways. And there are many people who have been declared brain dead and want to live for a long time. We mentioned Todd, Jahi McMath. Incidentally, Jahi McMath was in California, and her mother got on the TV and pleaded, will someone help? So my son was here and said, Dad, what are you going to do? So I got on a plane and I went to California. They wouldn't let any doctors in to see her. So how did I get in? Her stepfather was about 10 feet on the other side of the guard, and I was 10 feet on the other side. And he said, oh, Pastor, come on in here. And that's how I got in to see Jahi. And incidentally, her treatment got started right away out there in California before she ever went to New Jersey, and she lived another 4 years and with excellent studies by Dr. Schumann and others, was able to demonstrate clearly a functioning of her brain. When her mother would say, "Give me a thumbs up," her thumb would come up, and not immediately, because it took a while for that process. I saw her to raise her left leg, and she raised her left leg so she could hear, she could process, she could do that, and she fulfilled the criteria as documented by multiple physicians, and that kind of thing, and Jahai was not dead. She wasn't a resurrection for those 4 years. Todd, TK, was not dead. Aiden Alou was not dead. Alan, who now lives in Montana, was not dead. Charlie, who lives in Kentucky, was not dead. We were able to get treatment started on these people before they do the other things. Just see, people who are declared brain dead don't die if you keep treating them properly. If you support their breathing, their nutrition, their hormone needs, they don't die. They live for a long time. And in the course of all this, I can vividly recall reading about a patient in Colorado who had been in a vegetative state for 7 years, and then to do some work on his teeth, they gave him Valium, and he woke up. We don't know what's going to happen to the brain when we find better ways to treat. And yes, we have to find better ways to treat to stop any further injury to the brain, but to find ways to help it to heal. And so we need to keep doing that. And thank you, Dr. Akkad, for all you have done.
Thank you. Before we part, it's unfair, but I want to give Dr. Coca a chance to. He's been very patiently listening in the background here, and wonder if he has any thoughts to share here before we close.
Oh, I'm sorry.
No, it's okay. No, that's fine.
I didn't know that. I apologize. I thought it was helping technically.
Oh no! It's all good. He's hopefully he's you talked about Alan Schumann, how he converted from being a pro brain death to anti-brain death now, and we're hoping that Dr. Coca is on his journey as well here. So
I want to hear.
So it's interesting that there's quite a schism in the Catholic community as well about this very issue. So I think even if you play by even if you agree to the frame of life and death and the soul, and life ending when, or at least considering life ending when the soul parts from the body, this is all within again the frame that I think Catholics view life and death. Even using that same frame, you of course have a significant number of Catholics that disagree, or perhaps as you're saying, give too much deference to the medical community in terms of what is and isn't death. But it just does go to show that it is a relatively contentious issue with some degree of subjectivity even within that frame, but outside, so therefore it shouldn't be that hard to see why it is that folks that aren't raised in the Catholic tradition, who don't speak the same language, may arrive at kind of a different place on this particular matter. But the one question that I had was that what if you as a I think I know the answer here, but what if you as an individual predetermines that if something were to happen to you in some catastrophic manner, that you want your organs to be given away? Am I allowed to kind of have agency there, or if somebody then doesn't allow that because they say that, well, you don't meet our criteria for brain death, and therefore keep me sustained in some state, is that is that going against my particular wishes? Is that okay?
Well, the first thing I would like to say that each one of us is unique, and our organs cannot be transplanted to another person unless something happens to that other person to stop from the rejection. So God makes it so that organs cannot be transplanted from one person to another. Now, does God know how to interfere with that rejection process? Yes, He does it every time a mother is pregnant. The baby is foreign to the mother's body, but the mother doesn't reject it, because already when there's just a 2-cell embryo, the early pregnancy factor is in effect and interferes with that rejection process. So the basic thing is organs do not need to be transplanted. They can't be, because we found ways to interfere with the immune mechanism. But when the large majority of people who have an organ transplanted, do they not exchange one set of problems for another set of problems? And of course, one would say, well, it's worthwhile, better than the alternative. But at the American Heart Association, a number of years ago, when this was all starting, 80% of the patients who were on the transplant list got off the transplant list by just giving better treatment and care. So far as my own self is concerned, I would just have to say for myself and people that I love and care about, no organ transplantation. The teaching of Pope John Paul II and the Pope Benedict XVI has been very clear that you can't take a heart until after death. And as Pope John Paul II pointed out, that because it would be obvious if you did it before they were dead, that they would become dead. So that teaching about the heart is clear so far as the church is concerned. It's clear so far as I am saying. I don't speak for the church. I speak for Paul Byrne. Hearing what the popes have said and knowing what I know, the answer is full heart transplant. Well, why not? Because of what I just said, but also to get a heart out, it takes considerable operation. At one time, somebody said it took about an hour to get the heart out. Well, what happens during that time? The heart is beating, has circulation, has respiration. There is an interdependence of the cells, tissues, and organs maintaining that line of the body. And then without oxygen, without circulation, in a very short time, maybe 5 minutes, the heart would be so damaged you can't transplant it. The same thing holds true for the whole liver. And so when they're
but I guess
organs,
but I guess the question is, what if some individual like me is okay with with that? Meaning, I want, you know, my organs to be transplanted to someone else if, you know, there was some catastrophic injury to where, you know, regardless of whether what the
Sure.
definition, whether we agree on the definition of what is what
So
constitutes death or not.
you
You know,
want,
am I allowed? Is the individual? Am I allowed to say that if there's a catastrophic injury where, you know, I'm unable to breathe on my own, or I'm, you know, there's, you know, whatever. There's a bunch of different criteria one can, or, but suppose suppose I want to be in a state where I'm
well,
okay
of
giving up
course.
my organs. Is that something that is okay?
Of course. And we want to do something to help other people.
Right.
And most people that think in terms of the what you are proposing, they think they're helping people when they're dead. When in fact, when someone is a cadaver, there are essentially no organs that can be transplanted.
Right. I mean, I would say
Maybe with some
yeah.
extensive way you can get a kidney, but you can't get the organs unless it's a person who has circulation, respiration, and who is to say that that's cadaver when in fact
Right.
it would be foolish.
Correct. So we would say that you're okay doing that, just like you're okay. I mean, you have free agency to jump off the bridge and so forth, but you shouldn't be okay to force us to declare you dead when you're not.
Right.
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 I mean, if you do this and say you acknowledge that if you have a brain injury, you don't want to live in that condition, and you want to, in a way, commit suicide by proxy by having your organs donated.
Right.
You know, perhaps.
Right.
But that's different from saying.
Right. But doesn't that get around this whole argument of dead or alive? I'm saying, okay, fine. You can say, even if we say I'm alive by your definition, but I'm okay with my organs being given away in that state. That would be okay then?
I mean, there are certainly a lot of people who have come around to rejecting the definition of, you know, rejecting the concept of brain death as being dead,
right?
And saying we should allow organ transplants to proceed under certain circumstances or whatever.
Even if you're not dead by your definition.
Correct. The only problem is that then you run into the problem of homicide laws and so forth. I mean, because it becomes, right, because then there's an action that will kill you, which is the harvesting of your heart.
Right.
That will kill you. And that legally makes it very problematic.
Right.
And that's why it was so important for the law to push the charade that brain death is death. That's how they did it 40 years ago, because they precisely wanted to avoid this legal conundrum of, well, if you allow people, then you know, who knows, you may do it under pressure. People may do it, you know, I mean, how do you know that the conditions are fulfilled? I mean, it's the same thing with assisted suicide right now. I mean, we're allowing this charade to go by, but it's going to be a legal conundrum. It's only going to create a bigger legal problem and social problem down the line.
Sounds good. It's been a wonderful conversation.
Dr. Byrne and Dr. Zainer, thank you so much for joining us.
Thank you.